So you're gonna make signouts, and then you finish up your progress notes, and you'll be done. So signouts. This is the part probably that most important to me right now because I'm on nights. So how to give a very kind of like brief and to the point and giving a good idea sign up. And remember when we talked about the one-liner when we built in our HMP when we admitted the patient in the first place? If you have a good one-liner there, it will make your life easier. You're gonna copy that one-liner. You're gonna put it in the first thing in your, like when you do this shift handoff, there are three boxes. So the first box on the top, I usually put in the one-liner, and then I put in what was the chief complaint and what is the working diagnosis. And then after that, I put the active problems, and I cannot emphasize more the active, not the chronic issues. The patient is here for GI bleed. The patient is here for sepsis. The patient is here for hypoxia. Like he's here for a stroke workup. Whatever active that we are actually doing something different about. And you mentioned what are the active steps of management. Then when you go to the overnight part, you need to give an idea. I usually think about it system-wise. So you think about vitals, which is kind of like hemodynamics, like circulatory system. Then oxygenation status. Is he on room air? Is he on BiPAP? Is he on 4 liters? So this is like cardio and then respiratory. And then you need to give the GCS, and that's the neuro, plus the neuro deficit. Very, very important. Neuro deficit. I cannot emphasize more. We have a lot of people who have like a new stroke developing overnight. So if I don't know the baseline and you guys don't tell me, I will have no idea. And this is kind of like one of the issues that we can improve on all the time. And sometimes it happens and people get like scrambled. Is this change from baseline? The nurses doesn't know. The patient has been here for 2 days. Nobody documented like a detailed neuro exam. So nobody know, is this left-sided weakness new or is it a chronic issue? So very important to pick up on any neuro deficits, okay? Make sure you have that and the baseline GCS. So if any changes, we will know. And then if there's like an emergency contact that is not already on the chart, just put it in there so we know who to call if the patient situation goes south. We mentioned neuro deficit already, and then any follow-ups that I need to do overnight. So I come at 8 and I'm staying there for almost like 11 hours. If something I don't need to follow up during the 11 hours, probably you don't need to put it in the sign up. So lactic acid, the tropes every 6 hours, you need to tell me about. You have someone with like a hyperkalemia and it's not improving, you need to tell me about. If the patient's hemoglobin was like 8 the day before, it was 7.5 the day after, and you are not checking it every 12 hours, you're just checking it next morning, you don't need to tell me about. But if he's actively bleeding and you put an order for H&H every 6 hours, that's a trending that you need to tell me about. So just make sure that you're anticipating what's going to happen. You're trying to anticipate. Nobody knows everything, but you are trying to anticipate the problems because you know the patient better than me. I'm cross-covering for all the teams, so I am taking care of a large number of patients, and I barely know very glimpse idea about each one of them. So it should be very you know the patient better than me. So if you are not aware, you can ask your senior, you can ask your attending what to put in the sign out for the night team. Okay, and you will develop this skill throughout your intern year. So this is an example of a sign out. You're gonna put in like, for example, 67 male with. You're gonna copy and paste your one-liner. And then you're going to present with, and this is probably the chief complaint from the ED triage note. And then you're going to mention he was admitted to medicine for, what is the working diagnosis? Are we working up chest pain? Are we working up CHF exacerbation? Or is it like a stroke workup? You're going to put in the active problems, and you don't need to put in the hypothyroid, and you resumed him on his home levothyroxine. I don't need to know about that. You put it already in the one-liner, and I know he does have hypothyroid. and it's all good. Just mention to me the active problems. Is CHF exacerbation. We're currently diuresing, and his net goal is 2 liters negative per day. He also have elevated tropes, which is an active issue, and we're not really sure. Is it ACS? Is it probably demand ischemia? Cardiology consulted, whatever you put in there. And then for night team, you can mention he's hemodynamically stable on 4 liters nasal cannula. His GCS is 15, so I'm gonna know like he's already totally alert and oriented. And then he doesn't have a neuro deficit, so I know his baseline. And you're gonna tell me like I'm trending his tropes, and the next one will be at midnight. And anything else to anticipate? Yeah, if his urine output was slowing, then please give him an extra dose of Lasix. That's all I need to know about this patient. Problem solved. Move on to the next one. So it doesn't mean a good sign out means like it's extensive. No, it should be just to the point with the most relevant information in it. Okay.